So a very warm welcome to our audience joining in from across the globe. Afternoon, evening, from wherever you are. And my name is Sandra Yvonne Okech, and I work at the African Institute for Development Policy. Welcome to the second out of the 5 webinar series under the overarching theme, How Do We End Malaria in Africa? This second webinar will look at what are the threats to eliminating malaria from Africa by 2030, and what can we do about it. So this is to delve further on the persisting challenges in eliminating malaria from Africa and really looking at strategies to stay on course to achieving the global targets of reducing the malaria incidence and mortality by at least 90% by 2030. The webinar series is hosted by the Health Tech Platform, an initiative of the African Institute for Development Policy. And to learn more about our work, please visit our websites, healthtechafrica.org and affidep.org. The affidep social media handles are at affidep on Twitter and African Institute for Development Policy on Facebook and LinkedIn. The Health Tech platform social media handles are at HTP_Africa on Twitter and the Health Tech platform on LinkedIn and Facebook. So again, this webinar will have 3 sessions that will include a keynote address followed by panel discussions and a Q&A session. So many thanks to our eminent panelists for creating time for these meaningful conversations. I will therefore proceed to introduce our panelists. The keynote speaker is Mr. Bala Jata, who is the Epidemiology Surveillance and Neglected Tropical Disease Program Manager at the Ministry of Health in Gambia. Feel most welcome, Mr. Chata, and you could please have your camera on to say hello to our audience.
Hello, good morning from the Gambia.
Hello,
thank you,
thanks
Sandra.
for joining. Thank you so much. Nice to see you. Yeah, our other panelists are Dr. Michael Okal, who is the Director of Research and Development, Vector Health International Limited. Karibu sana, Daktari. You could also just have your video on and say hello to our audience today.
Hello, good afternoon, good morning to all of you. I'm happy to be here and looking forward to the discussions today.
Thank you so much, Daktari. So our other panelist is Professor Arti Prasad. She's the head of Department of Zoology at Mohanial Sukadia University. So, Prof, you can also just say hello to our audience. Checking to see if Professor Arti has managed to join.
Yeah.
Oh, okay.
Hello.
Hello.
And very good evening to all of you from India.
Hello, thank you. Good evening.
Hello.
Yeah, so again, our other panelist is Dr. James Chirombo, who is a biostatistician at the Malawi Liverpool Welcome Program. Most welcome, Dr. Chirombo. You can have your video on and say hello to our audience.
Hello, everyone. Good afternoon, good evening, or good morning. I'm joining from Zimbabwe. Thank you.
Thank you so much, Daktari. So our last panelist is Dr. Chris Baraza, who is the Chief of Party Amref Health Africa in Kenya. Karibu, Daktari.
Thank you so much. Good afternoon. I hope you can see me. Yeah, I'm looking forward to the interaction. Hope
Yes.
you can hear me. Hope you can see me.
Yes, we can.
Thank you so much. I'm looking forward to the discussion. Thank you.
Okay, so to our audience, please feel free to put in your questions on the chat box as we go along with the conversations. Thank you so much. So we will now go straight to the keynote address on threats to malaria control and the prospects for elimination by 2030. Over to you, Mr. Jatta.
Thank you very much, Sandra, and thank you everyone for this wonderful webinar series. And thank you for the trust and confidence you have in us as a country to be part of this very important webinar series.
No, we shared it on affidavit.
No, sorry, Adudo, there's some background noise from your end.
Really?
Not you,
Apologies, sorry.
Bala, not you, Dr. Bala. You're good to go. Yeah.
Okay. Thank you, Sandra. So we're going to talk about the threats to malaria control and the prospects for elimination by 2030. And this is a very important topic that you have selected to discuss. And a few of the threats that we are discussing will be the one key threat to elimination of malaria on the African continent will be urbanization. And this will want to talk about rural urban migration, which is one key aspect of or threat to malaria control. Because like for example, in the Gambia, we have extreme weather in the eastern part of the country. So people tend to move to the western parts of the country in search of better prospects, better jobs, and even a cooler environment. And they also bring along the vectors or the virus, the parasite along with them. Because the reason why we knew this is we have MRC Gambia at London School, which is doing a study on genomics, trying to follow cases from the eastern part of the country to the western part of the country and try to trace the origin of those parasites. So we've realized that urbanization is playing a key role in making the incidence of malaria higher in areas that we used to get very low incidence. And then another aspect of urbanization is infrastructural developments that are going on. People are building house structures, roads constructions are going on, and then we are not making, we're not giving consideration to waterways or
You're breaking. Can you hear me?
where that makes it very favorable for. Can you hear me? Hello.
Now we can. You broke
Sandra,
at some.
can you hear me?
Yes, now we can hear you. Please proceed.
Okay, can you hear me now?
Yes, now we can hear you. Thank
Good.
you.
Thank you. So what I was talking about is infrastructure development that is not making provisions for waterways, and this has contributed a lot in increasing the breeding sites of mosquitoes and other vectors. And this has also contributed to the high incidence or increase in malaria incidence in areas that development is going on. We've seen the people building in swampy areas that are very favorable for malaria breeding. And then another one we want to talk about is climate change. Climate change has increased significantly the incidence of malaria in countries, especially in the Gambia. One is a rise in temperatures. Rising in temperatures, just most of the mosquitoes, high temperatures favor mosquito breedings very well, and even reproduction. And this rise in temperatures have made it favorable, even areas that we are not experiencing breeding mosquito breedings have now become breeding sites for mosquitoes. And this has increased also, and it's one threat that is affecting our elimination or control strategies, because now we are seeing a shift in the areas of transmission from the high transmission areas to new areas that used to have low transmissions, now becoming high transmission areas. And then we also have drug resistance that we have experienced. Like, for example, in the Gambia, we used to use chloroquine in the treatment of malaria. And then people started building resistance with the chloroquine, and now we're using artemisinin or quaterm. But now we are also seeing in other parts of the world, people are building resistance to quaterm, which is becoming a problem for us. So the drug resistance, I think one key factor is continuous use of the same type of drug for a long time, and people become resistant, or the vectors become very resistant to those drugs. And then we also have the vector resistance. We are seeing the vectors being resistant to the insecticides that we are using now in the in treatment. For example, we are seeing now in Africa, we are seeing Anopheles stephensi, which used to be a breed in Asia. Now we are seeing it in Africa, because they're building resistance, and then we're also importing them into Africa, and we do not have the adequate technology to tackle those vectors that are coming into Africa. So when it comes to the prospects for elimination by 2030, I think I will only talk about two key prospects that I feel are a priority for us. And one is the use of technology. For example, the use of gene-drive technologies to bring new innovations in the fight against malaria. I think this is a key prospect that we as Africa we are using now to eliminate or eradicate malaria in the African continent. There are a lot of research and studies that are being done to ensure that we bring technology into the fight against malaria. The new innovations like the bringing up of new types of bed nets, like the PPO nets that we are using to at least minimize the risk of transmission, trying to sterilize or trying to reduce the efficiency or efficacy of the parasite in the mosquitoes when they come in contact with these nets. Those are two key areas that I feel are areas that if we invest on as Africa, or invest on as malaria control experts, we will be able to make headway towards the elimination drive of 2030. And without wasting much time, I think these two issues that I have dealt on, I feel if we discuss on this very well, we will be able to make way towards elimination of malaria by 2030. Thank you very much.
Thank you so much, Mr. Jatta, and for the thoughtful keynote address, particularly highlighting the key threats to malaria control. You've talked about the rural-urban migration, you've talked about resistance, you've talked about new vectors like the Anopheles stephensi mosquito, which all are great threats to malaria elimination. So with this, we will move to the panel discussions from these highlights and really have our first panelist, Dr. Michael Okal, discuss on to what extent is the effectiveness of insecticide-treated bed nets and also the indoor residual spraying declining And what impact does this have in reaching the 2030 goals? And what needs to be done to improve these tools? Over to you, Dr.
Thank you, Sandra. Can you hear me?
Yes, we can hear you. Thank you.
Yeah, I think I'd really first want to appreciate this platform AFIDEV is providing for having this kind of discussions, because I'm convinced as a person that this kind of discussions are really key in trying to develop new strategies and ways for dealing with malaria in Africa. And so thank you also, Mr. Jata, for setting up a good background to all this. Now, Sandra, I'm very passionate about mosquito control tools, and so I might rant on and on and on. So this is me allowing you to just mute me should I talk for too long.
Okay.
And all, yeah. Now, I think that sometimes when we think about malaria control, we tend to only see the negative bit of it. And so I thought in setting a background of this, I just wanted to remind us that 25 years ago, today we were looking at deaths of up to 2 children in Africa per minute from malaria. Now, to put that into context, in the time space of this webinar, 25 years ago, we would have 180 children dead from malaria. And so I think it's nice to, even as we look at the challenges we are facing, really appreciate the progress that has been made towards malaria control in Africa, with contribution from every sector, both within and without Africa. Now, many years ago, maybe perhaps 20 years ago, upon the discovery or demonstration of the effectiveness of bed nets and indoor residual sprays, artemisinin-based combination therapies. And when this got ramped up, the effectiveness of this in malaria control was so good that for the first time we saw many actors in the globe come together with intentionality to start thinking about eliminating malaria in many places and possibly eradicating it altogether. You know, just to give you this in numbers, by 2015, there was already a reduction of up to 60% to mortality due to malaria, and up to 37% decline in just malaria cases. And so it seemed as though everything was going well. A lot of nets had been distributed, so we are looking at somewhere around 582 million ITNs, with 505 million of this distributed just in Africa. And many experts agree that a lot of the decline in malaria we see between 2005 and 2015 can be attributed majorly to many things, but primarily due to ITNs, insecticide-treated nets. But in 2017, something changed. And that change was that the drastic decline we'd been witnessing in malaria suddenly stalled. And now, for the last 3 years, 2017 through to now, we see that in spite of increasing the number of bed nets, houses covered with indoor residual sprays, number of people treated with artemisinin-based combination therapies, there just seems to be very little progress towards eliminating or eradicating malaria. Now, I just need to be a little clear about this, that these tools still very effectively prevent deaths and lead to reduced cases. But it's the progress that we are making towards having a 90% reduction in mortality and incidence of malaria by 2030 that has stalled. And so in the next 5 minutes, I'm just going to try and share some bit of insight on why I think this has stalled and what I think we could do about it. So there could be many reasons as to why malaria control has stalled in spite of, interventions still going on and many people putting in both investment in terms of funds and tools. But what I really wanted to highlight that I think is a true threat for malaria control is resistance. Now, I'm going to do this in 2 bits. The first bit is vector resistance. So this is when mosquitoes become resistant to the classes of insecticides that we have. Now, the principle of a bed networking or an indoor residual spraying is quite easy. The whole idea is that when a mosquito gets exposed to this, it loses, it affects it. It becomes weak and later dies from this. And as a result, a bite, an infective bite is prevented. And also the mosquito is prevented from proceeding to contribute to the next generation of mosquitoes. And so insecticide resistance, which therefore means that mosquitoes are now able to be exposed to the net, but survive on to have an infective bite and also contribute to the next reproduction for the next generation, then therefore becomes a real threat for bed nets and also indoor residual sprays. Similarly, parasite resistance to drugs, and this is in the context of artemisinin-based combination therapies. Again, there the principle is simple. The idea should be that every time a patient is infected with malaria, they find themselves in a health facility and they're provided with the correct dose of these drugs, the parasite gets cleared and a death is averted. What would be detrimental to that is a case where you are exposed to a parasite, you're given a drug in time, but for some reason, the parasite is either not cleared, so you live and get sick again, or in the worst case scenario, you just stay sick, And just to give you a bit of background in this is that there are up to 88 countries that report the status of insecticide resistance to WHO each year. And 78% of those countries have now reported some form of insecticide resistance. Up to 29 of those countries in sub-Saharan Africa have now reported resistance to pyrethroids, which is the main constituent of bed nets. Now, taking together what I've just said, what this means is that there are now up to 29 countries where there are mosquitoes that can be exposed to a bed net or to an indoor residual sprays and still survive to inflict an infective bite and reproduce the next generation of mosquitoes. Similarly, there are studies that look at the therapeutic efficacy studies for ACTs. These are studies that track people who've been treated for malaria to try and see, they try to track outcomes for either clinical or parasitological. So you track someone you've just treated for malaria to see that has the parasite been cleared from this person and are they well after treatment? And in that, now there is evidence from Burkina Faso, from Uganda, from Angola, from the DRC, that in many situations there is up to a 10% drug failure rate. That is when you take the right dose of a drug and still remain sick. And so when you put together all this, I think what it means is that resistance, both by the parasites to drugs, and resistance by the disease vectors, the mosquitoes, to active ingredients, to insecticides, especially pyrethroid, really is a major threat to malaria control in Africa, especially considering that these are the frontline tools. So, to just answer your question directly about how this affects progress towards malaria eradication, or elimination by 2030 is that yes, it does affect that. And I think many experts agree now with WHO that we are 48% off track. And it's going to be quite difficult, if not almost impossible, to get back to track to eliminate malaria by then, unless something extraordinary happens, which I believe can happen. Now, it's not all gloomy news. I have to say that bed nets remain effective for controlling malaria. There's been very recent great progress with improving bed nets, having new chemicals on them, improving operations of how to deploy this better, intervening to improve the behavior of people to make nets last longer. And so this remains effective, and we're hoping to see that strengthened in the future. And I'd say pretty much the same thing for artemisinin-based combination therapies. They still remain the first-line treatment for malaria, and in most cases, they're quite effective for malaria control. So, I could go on and on about this, but I think I'll leave it for later discussions, just as we continue to open up on what I think we could still do to improve the effectiveness of these tools. Thank you, Sandra. Yeah.
Okay, thank you so much, Dr. Ari. And it's really interesting to note the high vector and drug resistance. And I believe these conversations will really give us further thoughts on really how best to achieve the set goals. And for me, I think it's really alarming to note that having up to 78% of countries reporting the insecticide resistance would really make us wonder in terms of just the efforts and strategies that have really been put into place for the ITNs, and also just the different vector control like the residual spraying. So thank you so much for those insightful deliberations. And I will move forward and invite Dr. Chirombo. And so, Dr. Chirombo, studies show that climate change has impacts on malaria elimination efforts. What are the specific impacts, and how can this be addressed? Over to you, Dr. Ari.
Thank you very much. Let me start by echoing what my colleague, the previous speaker, said about the enormous progress that has been made in malaria control. I think the fact that we are talking about malaria elimination in 2030, which is just 7 years from now, speaks volumes of the progress, the tremendous progress that has been made over the past few decades. Indeed, as the keynote speaker alluded to, climate change is a threat to achieving this goal in 2030. And all over Africa, wherever you look, we seem to encounter some kind of climate change or climate variation. And it has affected, and it is affecting all our countries, and all our efforts could be at risk if not properly checked. And let me just start by maybe acknowledging that I think climate change, the way climate change impacts malaria is quite complex. And I don't think we have got 100% hand on it, but we, as researchers, we know more about the interactions between climate and malaria much better than we did 10 years ago, 15 years ago. Just to give an example of the complexity, for example, climate, rainfall itself, it might, at some threshold, you might see that the rainfall is washing away all the breeding sites that you would expect to have malaria. So more rainfall would mean maybe washing away of the breeding sites, but at the same time, the same amount of rainfall can also create, in some environments, conditions that are conducive for the vectors. Drought, you might look at drought as providing the dry conditions that can make malaria breeding sites completely dry out. But at the same time, the drought can also leave the breeding sites with just the right amount of water for breeding. So I think it's not a direct relationship. So that is just to acknowledge the fact that it's quite complex and more has to be done. And if you look at the literature itself, some studies will say climate change, looking at maybe global climate prediction models, some research is going to tell you that climate change is going to maybe facilitate malaria elimination, is going to bring about conditions that are going to maybe accelerate malaria elimination. On the other hand, some studies will tell you that long-term climate change is going to increase the range of climate, the range of mosquito range, the range of areas that are conducive for malaria transmission, such that areas that were previously free of malaria, you then begin to see malaria reaching those areas, like in the highlands above 1,500 meters above sea level. So that's just a snapshot of how malaria and climate are intimately related, and it's so hard to disentangle these interactions. Now, coming back to the question, I think some of the pathways that we see how climate change is impacting malaria elimination efforts, we have got, with climate change, increasing frequency of extreme events. In the past, it was quite rare to have extreme events every year, maybe several times a year. But now it's common to have extreme heat, extreme rainfall. I'll give you an example of Malawi. I'm sure you, the past few weeks, maybe a month or so ago, you read about, or you saw on TV how Cyclone Freddy devastated Malawi.
Yeah.
It caused a lot of damage. And last year it was another Cyclone Anna, which caused damage in Malawi, Mozambique. The other year we had Cyclone Idai. So almost every year we are having these extreme weather events. And what these extreme weather events are doing is to, one, provide those environments that could be conducive for malaria, but also disrupting all the health systems. I think, as my colleagues alluded to earlier, there are a lot of factors that are contributing to this problem that we are seeing, infrastructure being one of them. So if a cyclone comes and just wipes out the already fragile health systems, then it makes us even at a delicate position to start to regroup ourselves. Yeah. So with these changes in the climate and climate change and climate variation, we are seeing, one, the extreme events, but also seeing changes in the pattern of seasons. Increasingly, we are seeing the rainy season, for example, where we normally expect to have malaria transmission, that being altered. We've got late onset of rainfall, or sometimes the rainfall will cease much later than normal. So all these things are disrupting the usual pattern of malaria life cycle, mosquito life cycle rather, and how that relates with malaria. So there is a lot that is happening that we need to get a hand on. Now, going further to maybe some of the things that we can do, at the moment, WHO is recommending that perhaps we should try to understand the risk patterns at the subnational level. Well, some of the models that I mentioned about area that predict conditions that are going to be conducive for malaria elimination, they are at the global level. And if we go by those predictions, we must start to think, the the predictions are telling us that conditions are going to be favorable for elimination drive. So we might maybe become a bit complacent. But if we look at a local scale, I think there is ample evidence that most of the malaria at a national level is driven by our local climate and our local dynamics. So we need to understand better the seasonal variation, intra-annual variation in climate characteristics in our countries, so that we are able to better understand how these changes in climate are related to malaria patterns. So that's one thing. And for WHO, they're emphasizing and encouraging us that we try to stratify the risk, the malaria risk by within the country. So if we stratify the risk, we might have areas of low transmission risk, very low transmission, medium transmission, and so on. So the idea is that we should be able to better target our interventions. So for me, the best way to facilitate this stratification, this risk stratification, is to make sure that we incorporate climate data in the stratification exercise. It's not enough to just look at malaria case data and do some modeling or any other exercise that stratifies our countries by these risk thresholds. But the stratification itself should also take into account the local climate characteristics, and that calls for working closely with the national climatic agencies that provide the local data for climate, but also working with global satellite data products from international partners, so that we kind of work with these two sources to have a complete coverage of climate, whether it's rainfall, temperature, humidity, anything that is related with malaria and that contributes to malaria transmission. So in short, in summary, what I would say is, is indeed a task that is before us to make sure we understand how climate change is threatening the ambition to eliminate malaria by 2030. And one way of addressing that is to understand at a local level how malaria is being affected. And it helps to look at maybe past extreme weather events, what happened in the aftermath of past extreme weather events, and try to build on that going forward. Thank you very much.
Thank you so much, particularly for really highlighting the climate change impact to malaria control and some of the suggested interventions, like particularly really understanding the climate patterns and integrating the use of climate data to help in the malaria elimination efforts. Thank you so much. So to our audience, please be reminded that you can put on your questions in the chat box, and we will have a session to ask these questions to our panelists. So please feel free to continue writing your questions as we go along. So our next presenter will be Professor Arti Prasad. And Professor, my question to you is the Anopheles stephensii mosquito is a native to South Asia and parts of the Middle East. It entered into Africa in the last decade. It thrives in urban setting. It's resistant to many insecticides, and is considered to be the source of at least one outbreak in Ethiopia, according to the World Malaria Report. So the species has been in India for a long time. What lessons can Africa draw from in terms of just the elimination efforts that India has been able to do so far. Thank you, and over to you. You're on mute, Prof.
Same time.
Okay.
And can I share my presentation?
Yes, please.
Okay, thank you. So a very good evening to everyone, to all my panelists, and I am so much thankful to Dr. Richards Mukavana, who has given me this opportunity to express my views on this very hot topic and concern for everyone on the elimination of malaria in Africa and India, and what lesson we are getting out of this. So this is a good topic that I have been assigned. I am going to give you a small introduction of position of system of malaria condition in India, and then I will be showing you in 2 or 3 slides, because I have been given only 10 minutes. So I will be showing you what we are at present doing in India to eliminate, because we are pretty successful in eliminating malaria from India by the goal decided in 2030, and our own national program for 2022 and 27 that we have decided to achieve this elimination program. So as we all know, and then 2 or 3 slides, I will be showing you what we are doing in my laboratory, because my laboratory is actively involved in this elimination process of malaria in this city of lakes. We have a topography quite resembling with that of your country, a continent. So we have hilly terrain, we have lakes, we have water bodies, and of course climate change is taking place so fast that we have just listened to from our speakers. So this week I can start. This is the first slide. That here we can see we have 6 species mosquito: Stephensi, Culicephacis, Flubatilis, Minimus, Sundacus, and Dirus. And out of this, we have maximum is Culicephacis spread all over in Indian region, and we have Stephensi also. Anopheles stephensi is quite disturbing and nuisance mosquito for malaria outbreak. Flubatilis is also, that is in the foothills, and Minimus, Sundacus, and Dirus. So this here you can see, this is the key identifying characters of Anopheles stephensi. I need not to go on this. So milestone targets for malaria elimination in India by 2020 is 15 low transmission states and union territory eliminate malaria from all these regions. By 2022, we have a target of eliminating malaria from all 8 moderate transmission states. By 24, reduce the incidence of malaria to less than 1 case per 1,000 population, and 27, interrupt indigenous transmission of malaria throughout the entire country, including all 10 high transmission states. So with this, we have divided into 3 categories. Category 0 is considered without any local transmission. Category 1 is in the elimination phase. Category 2, we have pre-elimination phase. There are many districts which are having in pre-elimination phase, and category 3 is intensified control phase. So this is the category 1. Here we can see these states are there, and I am not going to give names of all these, and I'm only talking about Rajasthan. From I belong, and I am talking to you from Rajasthan, and fortunately we are in the category 1. So this is a very pleasant situation for this state, that we are and falling under category 1. So this is the overall scenario of India, of our country. So far as malaria elimination program is concerned, we have reduced quite a lot malaria cases and death from 2001 to 2021. That can be seen here in the graphical representation. And this is the national policies and guidelines for malaria elimination that we are working on. We have national framework for malaria elimination in India and national strategic plan for malaria elimination from 17 to 22. And our Honorable Prime Minister has launched this program and we are working on this. So strategies for malaria elimination in India is basically on these points: case-based surveillance and rapid response, early diagnosis and complete treatment, integrated vector management, on which we are listening from our panelists and speakers just now, epidemic preparedness and early response, monitoring and evaluation, advocacy, coordination and partnership, behavioral changes, communication and community mobilization, program planning and management. These are the strategies that we are adopting here to eliminate malaria in our country by 2030. These are some of the photographs that you can see. These photographs are from my laboratory students that we are working on the field day and night to work on these strategies and points and goals that have been decided by our country program. And we are trying to collaborate and cooperate as much as we can. So these we can see, you can see we are bringing blood slides, we are doing day and night survey, we are sitting with the farmers, we are sitting with the people of the village in the night also, and we are explaining everything to them. So these are, you can see, integrated vector management programs we are running here. Monitoring and evaluation, we are doing actively, we are doing these programs in the laboratory, as well as just now one of my panelists was talking about the introduction and use of modern technology and tools in the elimination of vector control and elimination of malaria and vector control program. We are also using all the latest tools and techniques like bottle bioassay we are doing repellent assay, and we are using other tools also to eliminate mosquito larvae. We are using larvicides. We are going for IRS also. We are doing survey and collecting adult mosquitoes, rearing them in the laboratory, and then finding out the parasitic load also we are finding out. So these are the coordination with government departments and effective implementation. We are coordinating with these departments, forest departments, and basically I am on the tribal belt. So we have a tribal commissionerate here and tribal institute. So we are collaborating with the tribal department also and fisheries department. Still on basis of all these things, we have many challenges. That challenges I think we have here. I will just stop for taking the African point of view into the picture. So far as I have been given a topic that what lesson from India that Africa can learn or adopt, or the African people can follow. So we are pretty successful in malaria elimination. Still we have 2 or 3 very big challenges. That day I was talking to Dr. Richard Mukabana, and that day also I was discussing streamlined program and planning and management. Due to the lack of awareness program, we are facing a lot. And I think the same thing might be in the picture in your continent also, in Africa also, because we don't have much of the awareness program and we are not focusing on this. We have bed nets. Our panelist was talking about bed nets. I know that we are pretty successful in controlling malaria using bed nets and IRS. But unfortunately, I have gone through a picture and I have gone through a village here where bed nets have been given to the farm people of the household people and in every house, but they have not been told how to use these bed nets. So unfortunately, these people are putting their potato and onion and other things in the bed net. So that was unfortunate, and I was surprised to see why they were putting. They said, we don't know what for the government has given this. So awareness is the main program we have to run to eliminate malaria by 2030, we have to act on the small scale, not on large scale, because I am going to give you a punchline that is from focal to global. Focal, we have to focus on these small things. Transforming malaria surveillance. I was just going through some of the countries who are very successfully eliminated malaria, and they are zero malaria now. Like China, they have adopted 135 and 137 program. 135 is the first day you just see the malaria cases or point out the malaria. Third day, in 3 days, you just report it and investigate the disease, and up to 5th day you just take the drug, give the drugs, and stop the malaria from there and stop transmission. So 135, and then they have done this for 1, 3, and 7 days. By 7 days, they reduce the transmission, and the retransmission also is stopped. So such type of things we have also to adopt in next few years to achieve this malaria elimination. And I think I would like to suggest that you people also adjust or adopt such type of quick, fast diagnostic and strategic management program to eliminate malaria from your country as well as from my country also. So this and adopting this program by one state, Bastar, it is in Chhattisgarh, it is in MP. This area has freed this place from the malaria, and they have reduced malaria, and this is the program they have adopted. And I think this is the best thing that I can convey from here. Door to door visited by the survey team, they adopted this punchline programs. They visited door to door. They test, treat, and track approach they adopted. Provide local food to the malaria positive cases. They used wall stickers, stencils pasted outside the surveyed house. They did treatment. They used treatment card issued to malaria positive cases. When they diagnosed the people with malaria positive, they used this treatment card, and they then went to follow up the slide preparation after 1 month of treatment complete. And they had a very good surveillance program during small shopping centers, small camps of the farmers, small people, village fair, like village fair. They had surveillance there and awareness program there. Source reduction, of course, they have done. LLI and monitoring and whistling and ringing of the bell. This has done very wonder in the elimination of malaria in these small villages where the workers, ladies and gents, the small children, school children, they just go around the village here and there in each roadside, and they ring the bell and inform that that use the mosquito net, and they inform about the mosquitoes in the village roads, localities, and this was very effective, and this model was adopted in this area, and they freed this area in India with the help of these points from malaria. But unfortunately, all districts and other areas have to follow this stringently, very strictly, and in a disciplined way. We have to follow this. So this is my laboratory contribution. You can see here we are going to the schools, we are going to every corner of this area, and surveying for the Anopheles larvae, reporting to the public health administration, and they are doing their work on the basis of the data we are providing. So this type of collaboration and liaising is also very important, because we are in the university and we have a lot of resources, and we can utilize these resources. We have 50 students every year, so I utilize these resources to send them into the villages for survey, active surveillance, day and night surveillance. They approach each and every school and educate the school children, and then in turn we collect the data and we provide it to the administration, local administration, and then we ask that you can make the policy on the basis of such type of data, because we have always lack of human resources. We don't have good entomologists here also, and I think it is the more or less the same condition. So instead of waiting for those skilled person to come into the picture, such type of resources can be trapped, and they can play a very important role in the elimination of malaria by our and achieving our goal by 2030. So and we, on the basis of this, we have conducted a very good international training of 6 countries where Sri Lanka, Bangladesh, and all participated. So here we can conduct such type of training with your institution also, if it is possible, to give all-round training on the different aspects of vector biology, vector ecology, and different types of techniques that we are using here. So what we are lagging behind and Africa can rectify, I am giving one only this punchline, that is from focal to global. Be focal while you are going to eliminate malaria, and we will be in a global position to eliminate malaria. We will eliminate malaria, and Africa will, I think, if it is following all these things very stringently and in a disciplined way, phase-wise manner and time-bound manner, so they can also do the same thing. Time-bound response in form of case reporting and management, rapid vector control response, and elevated community participation, continuous epidemiological and entomological surveillance that we are advocating, and also I am also suggesting on my part, and I am just sharing all these things with you also, so that you can also take this into account. And trainings and capacity building, as I told, this is the most important pillar as so far as the malaria elimination program by 2030 is concerned. We have to go into the each and every corner of the village from where we are getting malaria cases, since Anopheles stephensi has invaded in your area, which is carrying falciparum as well as vivax malaria, and it is overtaking other mosquitoes that they are spreading. So this is a training program and capacity building to identify this Anopheles stephensi in different areas, their sibling species in different areas, these species as, and some of them as biological indicator, because most of the Anopheles stephensi we find at a place where we have Aedes larvae. So this is another important point, that we have to train to our local people, we have to train to our local villagers, to housewives, to school children, to everyone about this, so that they can take their responsibility and participate in the and contribute in the malaria elimination program. It is not the program of the institution and officers and administrators. It is a program of each and every person of the country. So private, and other important thing is we have to involve private sector also, because when we take the data from our government agencies and public sector, we don't consider the other data. So we have to find out the complete data. We have to make a data pool bank, so taking all the incidence of malaria here and there for vector, on the basis of the vector surveillance as well as the parasitic surveillance. So use of quality diagnostic. So inclusion of prevention and re-establishment program into elimination plan, residual transmission. So far one of my panelists was talking about bednet. I know bednet is very, very successful, but still we have little bit of residual transmission, and that in the long run that play a very important role in the and hinder the program of malaria elimination. We have to take care of this residual transmission, higher investment in research areas, and successful implementation of funds from the government. Since here also policymakers are involved and they are listening to this talk, I request them to make such policies where you can fund them, the people who are working in the field who are taking care of the program in an uninterrupted way. Sometimes lack of fund also stops the program, and in the long run we fail to achieve the goal that we desired. And multi-drug resistance in parasite and insecticide resistance in vector is another important thing that has to be checked every little bit of time. In a very short interval, we have to see the resistance in the vector species, because this is very important. Vectors are very, very intelligent, and they are developing resistance. Here in Rajasthan, we have taken a project of 150 million, where we are monitoring the resistance in the entire south travel belt of Rajasthan, and we are finding that very frequently they are changing their resistance level, and we are generating the data. I hope by next year we will be able to provide data to the administration on on insecticide resistance with on Anopheles as well as on Aedes. So climate change naturally has important role to play. Cross-border checking is also very important, because the people are coming and going from here and there, and one infective lot of mosquito can enter into your country, and they can establish very, very soon, very quickly they can establish. Anopheles stephensi is very clever mosquito. It can find a small place where fresh water is there, water tanks are there. In Rajasthan, Western Rajasthan, we had no falciparum, but due to the development of irrigation canal, we had developed this falciparum due to the migration of the labor who came from northeast and other places, and they established falciparum in western part of Rajasthan just due to this development of infrastructure and canal system. And luckily, we have conquered and we have achieved success in Western Rajasthan simply by one measure, that covering the lid of the water tank. All water tanks were closed with the lid of iron, and 80% of the falciparum outbreak was controlled. So I am advocating. Yeah.
Thank you so much.
So thank you so much. And I'm sorry, 2-3 minutes.
It's okay. Thank you so much.
What I have. Thank you so much. Thank you.
Thank you so much for the insightful and really exciting to learn what India is currently doing regarding the Anopheles stephensi mosquito eradication, the progress in terms of surveillance, the early diagnostics. And interesting is the sectoral approach that you've talked about, integrating education sector, women programs, and all that. Of just so thank you so much, and sorry about that. So just pushing forward for the time for our next panelist. And so our last panelist is Dr. Chris Baraza. So Dr. Baraza, the malaria report highlights about 63,000 deaths from malaria between 2019 and 2021, sorry, and mainly attributed to the COVID-19 disruptions. So how resistant are our health systems in dealing with future pandemics, and that can possibly stall the efforts towards malaria elimination? Karibu, Daktari.
And thanks so much. Allow me to project, or if my slides can be projected, I'll be appreciative. I think I'd send them earlier.
Please proceed. Yeah, you can proceed and project your slides.
I appreciate. Thank you so much. And thanks for this invitation. Thanks, Prof, for reaching out to me for this very critical presentation. I'll try and just have something for the next 10 minutes. The topic of resilience is very dear to me because I believe I'm a resilient survivor of malaria when it almost ended my life at a very early age of about 10 years. But nevertheless, we are here, and COVID-19 has had an impact, not necessarily on malaria, but on very many other diseases that we've had. And by and large, we've had very many disruptions, starting from diagnostics to access to healthcare. And I think most African countries, if not all African countries, were never prepared for COVID-19. And that's why we had a lot of aftermath, a lot of effects of COVID-19 when it comes to disrupting health systems. There are quite a lot of work that's going on. And in terms of just, let me put this on my charger. Sorry about that. So there's a lot of work going on in as far as building resilient systems is concerned across board. But there's some fundamental questions that we're asking ourselves, and I'll just take us through probably a framework that most organizations are using to be able to really assess how resilient healthcare systems can be. So by resilience, basically we mean the capacity of healthcare actors, institutions, and populations to prepare for and effectively respond to crises, maintain core functions when a crisis hits, and informed by lessons learned during the crisis, reorganize if conditions require it. So what we are talking about is, if another COVID happened or another pandemic happened, are we ready to, as a healthcare system, to be able to overcome this, and how prepared are we for the next pandemic? Because a matter of when, it's not about whether it will happen or not. It's about a matter of when it's going to happen. There are quite a number of pandemics that happen in African countries. And we are looking at resilience dividend, and this is really a point where we want to have improved performance, whether we are in bad times or good times. So are our health systems able to reap these dividends that we're talking about? And just going back to malaria a bit, we have goals, milestones, and targets for the Global Technical Strategy for Malaria 2016-2030. And for us to have an end to malaria, there are just 4 goals here: reduce malaria mortality rates by at least 90% by 2030, reduce malaria case incidence by at least 90% also, eliminate malaria in about 35 countries, and then prevent reestablishment of malaria in all countries. So the 4th one speaks to resilient health systems. How can we be resilient so that we can prevent a reestablishment of malaria in all countries? So the frameworks that we are using, most actually countries and entities are using this framework. I thought I would just share this to inform some work that is going on and that is being published across board. And one of the critical components is being aware. I won't go into details about this, but just being aware as a country, as a health system, that do we have potential threats in the countries we're working? And as one of your colleagues mentioned, climate crisis is a potential threat to our health system as we speak now. It may not be an infection like Corona was, but you realize that just about 45% in Kenya, for example, of the population is living in either arid or semi-arid populations. How much of a threat is that to health systems, and how does that relate to malaria, as an example? How can we have strategic health information systems and epidemiological surveillance planning and simulation? And this is the work that actually most policymakers like AFIDEP is doing, actually, to just be able to have proper surveillance mechanisms that can be able to build a resilient health system. The second component is diversity, so ability to address a broad range of health challenges. And I want to talk about specifically about primary healthcare services. So how do we manage our primary healthcare services? When I was very young and I used to get malaria bouts, I could quickly run to a dispensary those days, and I could get my chloroquine tablets. Sometimes I could get quinine jab. But I'm just asking myself at this point in time, how functional are our primary level healthcare facilities to be able to manage that? Because if we don't actually take care of that at that very early age, then you find that by the time someone is getting adequate medical care, they have actually complicated with malaria. The third thing is adaptivity, and that calls for flexible leadership, data utilization. I'll talk about that a bit more, that are using our data appropriately, and then structures and management systems that allow pivoting of services. The other component that leads into this is integration of actors, information systems, because we most of the times work in a very fragmented healthcare setup, a health system that's self-regulating. Are we able to isolate and contain health threats that we are talking about? So those 5 components are very critical components as we establish resilient health systems. And we are now talking a lot about getting self-reliant. Are we self-reliant as healthcare systems in Africa? And that's the biggest question we're asking ourselves. How can we be self-reliant without necessarily depending on donor money to be able to actually manage our own issues as they are? And we're expecting such outcomes as surveillance, very good surveillance systems, maintenance of core functions, reorganizing of functions. And by the end of the period in 2030, we want to really have controlled malaria by having an impact, reduce malaria incidence and mortality by about 90%. So going on to the next issue, just looking at the strategic objectives that the end malaria strategy has, being optimizing the quality and effectiveness of country and regional programming, maximizing levels of financing, facilitating the deployment and scale up of new products. So are we aligning ourselves to resilient health systems? And the answer is yes. There's a lot that actually is happening globally. And if we can gravitate our thoughts, our efforts towards this, we are speaking actually to resilient health systems. But there's one thing about having very good strategies and one thing about implementing most of these strategies. So most African countries are asking ourselves, with very good objective strategies that we have, what are we doing about the implementation? And there are some enablers that have been very well captured again in the strategy. Data sharing and use, you cannot talk about something if you don't know more about it. Effective partnerships, how can we be more efficient, more effective in as far as our partnership models are concerned? Targeted advocacy and the communications, how do we ensure that the mosquito net that we are providing is actually being used efficiently through communication channels that we have? There are stories of, people, especially from where I come from in Western Kenya, using mosquito nets to take care of their kitchen gardens. For them, mosquito nets is very good for protecting their sukuma wiki from being fed on by chicken. So how effective is that? When you say you have given mosquito nets, 10,000 mosquito nets in Western Kenya, how about the utilization of these mosquito nets? Then, of course, a focused secretariat that can be able to really support all these interventions, because malaria does not work on its own. We have a very fragmented system, that I said. Malaria is there, HIV is there, TB is there. How can we have an integrated programming that can be able to support all these interrelated functions the way we talk about? What does that mean? That we must have very essential public health functions that are aimed at improving, promoting, protecting, and restoring the health of all people. And that's what resilience is all about. Restoring the health of all the people, learning from what has happened before, and being able to really bounce back and support the initiatives that are there. Building strong primary health care as a foundation for bringing health services closer to communities. And we are doing this by having what we call differentiated population-based service delivery models. So if you go to ASAL counties like Turkana, where some of our activities are, we are asking ourselves, is the model of primary health care similar to Nairobi, where we don't have, where the access function is very different from the access function of Turkana County. So can we have differentiated models and then be able to cost them and say, yeah, when you go to Turkana County and other ASAL counties, we are going to, for example, use community healthcare providers to do what we call, what they are calling now tomorrow. Are they going to implement that and make services more accessible? When you come to Kibra, what are some of the access bottlenecks? So we define that and be able to come up with strategies that can be able to deliver the services in a better way. All hazards, emergency risk management that strengthens the ability of countries to prevent and tackle health emergencies. And Africa now, there's what we call the Emergency Response Fund that has been set up. And we are asking ourselves, by CDC Africa, we are asking ourselves, what can we do in the event that we have another pandemic? So they are pulling together resources to just prepare themselves to be able to respond to that in case another COVID quote-by-quote happens in the next few years. Engaging the whole of society so that all sectors work together towards a common goal for all of us. The paradigm shift, therefore, is my last slide, is really looking at what's the impact of climate change and the effect on the mosquito in the malaria world. Because a lot that happens, just as mentioned by one of my colleagues. Differentiated primary healthcare service delivery models, very critical. It's never business as usual for all other, as there's no fit for all strategy, but just having a differentiated care that can be able to really deliver services as appropriate. Integrated service delivery using a primary healthcare model, and then transformational partnerships, not really transactional partnership that we've been having for a long time. Through this, we can be able to discuss data, we can use data and transform the interventions that we have for us to be able to achieve a resilient healthcare systems. I want to give you a quote that I always want to talk about, that thanks to my parents and the dispensary nurse that I mentioned earlier, I survived several malaria attacks. At the age of 10, I had developed resilience to this lethal infection, making a commitment to become a doctor and join the fight against malaria. And that's where I am. That's what we are going to be doing. Thank you so much for the chance.
Thank you so much, Dr. Baraza, for enlightening us really on the resilient health systems and just the need to having strengthened primary healthcare systems and the overall preparedness in terms of emergencies and pandemics. So much appreciated for that. So we will move to the Q&A session. I believe we have comments and questions from the chat. I'll start with Edwin Ochomo. Thank you so much for joining. Edwin has talked about the need to, so with the mosquitoes colonizing new habitats, it's time to change the control strategies. So he's in agreement with this conversation that you're having. And then we have Nehil, who asked about whether malaria is contagious or infectious. So I'll leave it up for any of the panelists to respond to that question from Nehil. Is malaria contagious or infectious? Any of you can take up the question, feel free. Prof, you can take that up.
Sandra, I think malaria is infectious.
Thank you.
Yeah, thanks.
Malaria is infectious. I was hoping Dr. Chris Baraza will take that.
Yeah, I was trying to unmute it. Actually, you are right, Michael. Malaria is infectious, basically because it's transmitted from one person to another through a vector. So you have to have a mosquito before it moves from one person to another. Contagious diseases are usually the ones that are transmitted from one person to another, but usually through contact, direct contact. Like you have a skin disease, you get a direct contact with someone, so you call that a contagious disease. But malaria is generally an infectious disease.
Thank you so much for the clarification. Is there any question maybe that I may be missing, Adudo?
Yes.
Okay.
Hello. Yes, we have some questions from apologies from Ethiopia. I can't pronounce your first two names. So she or he has two questions. The first is, what is the effectiveness of the TMDA? Apologies, I don't know the acronym, in selected districts to eliminate malaria in a country with limited resources like Ethiopia. And the second question is the use of RDT, I know that one, rapid diagnostic test, in secondary case investigation to eliminate malaria, as well as the issue of asymptomatic case diagnosis by RDT is not feasible. So what is your recommendation to investigate / diagnosis and asymptomatic case diagnosis in the community? I would also put it in the chat for everyone to see. But perhaps the first question, maybe Dr. Baraza, you might be able to take that question because I'm not sure, or Professor Prasad. And the second question as well for Dr. Okal, perhaps it might be more appropriate for you. I've put it in the chat.
Thank you, Dudo. Over to you, our panelists, for the responses to the questions.
We also have one, perhaps also for Professor Prasad. Are there mechanisms to prevent invasion of non-native species of mosquitoes into a country? I think perhaps if, because of time, maybe we can have.
I'm not getting the question. Can I see in the chat box?
Oh, okay, let me put it there.
What is your recommendation? Investigation.
Yes, so I've put it in the chat box.
That can be, I think, the second question. Diagnosis is by RDT and is not feasible. So what is your recommendation to investigate?
Prof, the question to you is, are there any
this we also in our country also, when I visit to the villages, this where RDT is not available. Sometimes what happens that these positive cases are recorded through this blood test, and the second year also we find the malaria cases, relapsing malaria, and the villager, they think that they have some different disease, not the malaria that they encountered previous year, and so they start taking their own medicine, and they just at the end they end up with some other type of issues. So this is, I think, where this facility is not available, the awareness and contacting person to person and issuing that card, that has played important role in my area where we have made this malaria free, can be a very good substitute, can be a very good inclusion. What I think.
Thank you, Prof. There's also this other question. Are there any mechanisms to prevent invasion of non-native species of mosquitoes into a country?
Yeah, there is no such hard and fast rule, I think, but precautions and awareness that I was talking about, that you have to take utmost important, what we did in case of the COVID. Just see the example of COVID. We just banned everything. So people were very conscious about this. So trans-border migration of the labor and the people who are coming from this malaria-prone area into the area where there is no invasion of the mosquitoes can be checked strictly as we have checked the COVID. So there should be some administration check post where we have to take rapid test and see whether the person is suffering from malaria or not. If they are suffering, they have to be detained for 1 or 2 or 3 days until we administer the drug, and then we can allow them to enter into the country. So there is one possibility, if we do it strongly, very religiously, if we follow this, we can be able to check this up to a certain extent. Then there is infrastructure development, that there also we have to go for a regular checkup of the labor or the person who are working on these infrastructure. So it should be a routine. It should be a routine checkup on these places so that we can stop the entry of such type of things into the area. For example, I will take one example of this filariasis. There is no filariasis here only in the northeastern states of India. But due to the migration of the labor in the Indira Gandhi canal system in western part, there is a quite possibility of these labor to bring filariasis into this region in Rajasthan. So if we are checking them regularly, just for checking them regularly, just for the infection, so that way we can I think to some extent we can control the invasion of the mosquito spreading malaria.
Thank you. Thank you so much, Prof. One more question to either Mr. Jata, Dr. Baraza, or Dr. Kal. What is the effectiveness of the targeted mass drug administration in selected districts to eliminate malaria in a country with limited resources like Ethiopia?
I can give it an attempt. Thanks for that. And WHO has given that as one of the recommendations for actually eliminating malaria by 2030. And there are quite some publications about some work that has been done in different countries. There are countries that have actually done a costing of that, because what basically this means is that you give a therapeutic dose of an effective antimalarial. Most of the times you use piperaquine based combinations in a usually falciparum, Plasmodium falciparum infested areas, because that's what has been shown to be effective. So you give this therapeutic dose to a population that is that has an endemic population for that matter, whether the patient or rather the population is symptomatic or not. And because the reason why we do this is because the malaria parasite sometimes hides, quote by quote, hides in the system. And we've also done this among pregnant women because of the fact that the malaria parasite, as a gynecologist, I'll give in an endemic area, I'll give the SPs in this country. Usually we will give SPs for women who are pregnant in the endemic area, because the malaria parasite hides in the placenta of a pregnant woman. So sometimes you may not see the parasite in the bloodstream, but you want to access it by a particular dose of antimalarial that you are giving. So it's akin to that, and this happens in a particular population setup, and you are able to actually consistently give a therapeutic dose of a particular antimalarial drug that stays within the bloodstream for a long period of time, so that you can be able to control any infection that, quote by quote, and hides from the areas where we call them sentinel areas, where they are hiding, quote by quote, within the body. So that has been proven to be effective in particular parts. But whether the cost effectiveness of this is what has not been studied at length. But what we know is that this intervention can be a bit costly, because there are some prerequisites that you again must be able to achieve. And one of them is basically doing a proper surveillance, having a proper access to the commodities, ensuring that actually the people that you are starting the treatment are available, because you'll be given this treatment on a frequent basis based on how you agree. And then, so the cost of that may be a bit limiting to most developing countries, so to speak, but it's an intervention that has been tried out, and it's an intervention that can be very effective if we do it in the right way, for that matter. Thanks. Back to you.
Thank you so much for that adequate response. So we will now maybe go to our chat box, and we have a feedback form which you, our audience, can fill. Please take some time, a few minutes, to fill it in, and you should be able to get access to the presentations made from this webinar after completing that form. So we'll give ourselves some few minutes, please, for you guys to give us feedback on what it is we may include in the future webinars, and also just a feedback on how this webinar process went. So I believe we are filling in the form. So as we fill in the form, I'll just go ahead and give you some additional information, the plugins for the next webinar. But before that, I would really like to appreciate our panelists for today. Thank you so much for creating time for the very in-depth deliberations that we've had with you, and really getting to have conversations around best ways of really achieving the 2030 set goals, where we are at, what are some of the things that we really, in terms of interventions that we really need to input towards that effort of reaching that target. So just to let us know that our next webinar is slotted for Tuesday, May 23rd. And the discussions will be on what should African countries do to ensure investments and sustainable financing mechanisms for malaria elimination. Please feel most welcome to attend the session, and have a great, fruitful day and week.